Good morning. Thank you to Teresa for arranging this, and thanks for having me. I think I know a few people in the room. So it's good to see you this morning. Little disclaimer, I got very little sleep this past week, and I threw these slides together last night, so bear with me if I miss anything important. So, as Teresa said, I am the Executive Director of the Transplant Institute at Methodist University Hospital. I'm a professor of surgery, and I'm the Division Chief for Transplant at UT-HSC. So I was given the challenge of talking about chronic liver disease. Disclaimer, I am not a hepatologist. I am a transplant surgeon, so I deal very little with the stuff that I'm going to be talking about, except at the end. So chronic liver disease, it's a progressive deterioration of liver function for more than 6 months. It involves a disruption in the production of clotting factors and other proteins, detoxification of harmful products from metabolism, and the excretion of bile. It's brought about by a continuous process of inflammation. There's destruction of liver tissue and liver cells, and then regeneration and replacement of those cells with scar tissue, eventually leading to fibrosis, and then the end stage of that is cirrhosis. Looks like I worked so late last night I forgot to take bullet point number 3 off of there. Anyway, this disruption of architecture leads to the formation of nodules, which eventually interrupt the blood flow and cause many of the complications that we all know from liver disease. Some facts about liver disease. About 2 million people die from liver disease worldwide every year. 1 out of 3 people will die are women. It is the 11th leading cause of death worldwide. It is the 10th leading cause of disability associated life years lost in the world. And the cost of liver disease in the United States as of 2016 was just over $32 billion. 2/3 of those costs are attributable to inpatient and emergency department costs. So it's a pretty significant burden on society, pretty much financially, and in terms of not only the costs for care, but also the lost productivity. Really quickly, the etiologies of chronic liver disease. So the most common ones we know about are chronic viral hepatitis, that would be hepatitis C and hepatitis B. As many of you are probably aware, hepatitis C is declining as a problem that we're really seeing because of the drugs that have been out for about the past decade now. Toxins, alcohol being the big toxin that we deal with, although there are other ones, such as some of the commonly used drugs like amiodarone and some other drugs like that. Genetic causes, these would be things like Wilson's disease, hemochromatosis, alpha-1 antitrypsin deficiency. Metabolic related diseases, so that's, the new terms now are metabolic associated dysfunction, fatty liver, and metabolic associated steatohepatitis, formerly known as NASH and NAFLD, as you know in the past, but the nomenclature has recently changed. Autoimmune diseases such as primary biliary cirrhosis, which I believe I missed a talk on because I got arrived late. Primary sclerosing cholangitis, and autoimmune hepatitis, and then vascular diseases such as clotting diseases where you end up clotting off your hepatic veins and you develop what's called Budd-Chiari syndrome, which goes on to lead to cirrhosis. Just a quick look at this map. In the upper corner, it shows the, this is actually the alcohol use rate in the United States and the rest of the world. And as you can see, the United States kind of sits in the middle. There's a lot more alcohol use throughout Asia and Europe than in the United States. However, deaths due to alcohol, we do sit fairly high, but not nearly as high as still happens in Asia and Europe. This looks at the prevalence of fatty liver disease, actually, and the United States is near the bottom, even though we have a a high amount of obesity in the United States as of 2020. But these are the diseases that are more commonly being transplanted today and that we're seeing decompensated cirrhosis for. If you went back about a decade, 15 years ago, hepatitis C was probably the big disease that was accountable for decompensated liver disease. Alcohol was always number two. It was predicted that fatty liver disease would take over that within the decade, and we're approaching that right now. However, we had this little thing called the pandemic a few years ago. As a result of that and the depression and the isolation that occurred with that, alcohol use has skyrocketed, and alcohol has now taken over number one and remains the number one reason for decompensated liver disease. Yes?
May I ask, sir, the steatotic liver disease numbers, are those incidents, or do you think that it's a false low number because not enough of it's been diagnosed?
It's probably a misdiagnosis. I mean, and part of it is too, there's still this categorization of what's called cryptogenic cirrhosis. That's basically saying we don't know the cause, but the majority of those are probably fatty liver disease also, and they're not getting categorized in the fatty liver disease category. So, the clinical manifestations of chronic liver disease. So, what ends up happening is this restructuring of the architecture of the liver leads to a difficulty in blood flow getting through the liver. And if you think about it, if in the normal sense of how it works, the portal vein is the 240 for getting blood from the intestines back to the heart. What ends up happening is you throw a traffic jam in the middle of 240, and so the blood needs to find its way back to the heart because that's its destination, so that it can get on to where else it needs to go. And so with this traffic jam in place, it finds alternative routes to get there, and that's where the varices come from. So the alternative routes are, now everybody's getting off of the Union Avenue exit, and they're cutting through town, and they're trying to find their way back to wherever they're trying to get to, which in the case of these blood vessels or blood cells is the heart. So as a result of those traffic jams, and as we all kind of deal with in these traffic jams, we get frustrated and we get angry and we get late for where we're going, and we try to find alternative routes, and it just complicates our lives. So just like that, in liver disease, the same complications are happening. And these, you get the varices, and what can happen with the varices is that the veins are very thin-walled. And so it's easy to just scrape a vein wall and have it rupture. And so that's what happens with esophageal varices, and then you develop, a GI bleed, and then that can be life-threatening, and that is the most common life-threatening complication of decompensated liver disease. Next are caput medusae, where that's where if you have severe enough portal hypertension, the blood vessels on your abdominal wall and around your belly button will actually dilate and become under pressure, and we see that pretty commonly. It's not that common though, but we do see it. What's more common is the umbilical vein, which is when you're developing in utero, is the connection that basically takes the blood back from the placenta into the baby and get it back to the heart, is a connection from the belly button to the liver. That vein normally will obliterate after it's no longer being used while you're growing up. It will recannulate and will become a large engorged vein. And then when that pressure builds up, that's when you start to develop these veins that appear on your abdominal wall. Rectal hemorrhoids, because the hemorrhoid system is also a connection to the systemic circulation, which will allow the blood flow to get bypassed from the liver and back through the intestines and back to the heart. Ascites. So ascites occurs for multiple reasons, but it's primarily this backed up pressure in the veins causes the ascites, on top of poor building blocks for nutrition and low albumin and low proteins in your blood to keep that fluid inside the blood vessels. And then one of the complications of having ascites is that bacteria can translocate across the wall of the intestine, and in most of us, we can handle that pretty well, but when you have this rich broth of ascites fluid there that provides a good nutritional balance for the bacteria, they can continue to grow on top of the fact that you don't have the strong building blocks for your immune system to develop antibodies and have antibodies to fight that infection. So you can develop what's called spontaneous bacterial peritonitis, and that leads to hospitalizations. And then the other things that occur are just related to insufficiency of the cells themselves, not able to do their job in terms of protein production, clearing the bilirubin from the bloodstream and processing it and getting it out into the bile. So you develop jaundice. You develop these toxins that can develop, where you develop encephalopathy. Has 4 grades, as we all know. Grade 1 being just some mild confusion, but you're really able to function, all the way to grade 4, which is a coma. And then the gradation in between is basically increasing lethargy and sleepiness. Hyperestrogenism occurs. This is primarily a problem that occurs in men. You don't really see it in women because women already have a lot of estrogen, but in men they can develop breast tissue. They can also have testicular atrophy related to having too much estrogen and not enough testosterone within their system. And then coagulopathy, because the clotting system is deranged, because the liver is responsible for the production of those proteins. And so what ends up happening there is that you can actually become, coagulopathic, where you bleed very easily. You can also become hypercoagulable, where you clot too much. And so we see both of these problems in people with chronic liver disease, where they actually can bleed very easily, but on top of that, they've already clotted off their portal vein because they have a prothrombotic effect related to having a derangement of those proteins. And then the final thing contributing to coagulopathy is, with the portal hypertension, one of the other places that the blood flow coming into the liver from the portal vein is coming from is the spleen. And the spleen's job is to kind of clean up old blood cells, whether that's red blood cells, platelets, or white blood cells. And so what ends up happening is the spleen increases in size because of the backing up of the blood, and so you have a decrease in your platelet count also, which contributes to the coagulopathy. And the final thing is that the function of the kidney is intimately related to the function of the liver, and as liver function declines, you start to see some decreases in renal function, and the end result of that could be end-stage renal disease related to hepatorenal syndrome requiring dialysis. So when you look at it, there's about 1 in 112 million compensated cirrhotics in the United States, not in the United States, in the world at any given time. But over every year, about 4 to 12% of those patients will develop decompensated cirrhosis. The mortality of compensated cirrhosis is relatively low. You're actually a five-fold increase compared to the general population. However, the majority of people with compensated cirrhosis are going to die from the things we all die from: heart attacks, strokes, cancers, accidents, and things like that. The survival for somebody with compensated cirrhosis at age 67 is 5 years, and at 87 is 1 year, which is probably not much different than the general population. However, if you look at patients who have decompensated cirrhosis, which is about 11 million people across the world at any given time, the mortality is tenfold higher than compared to the general population, or twofold higher than people with compensated cirrhosis. Their survival at 75 is only 1 year, and at 45 is 5 years. And their reason for death is directly related generally to their liver disease, whether it's an infection, a bad hemorrhage, or just overall going into multi-system organ failure as a result of their liver failure. So the treatment approach, the goal is to stop the progression of the disease and the complications, and this usually requires a multidisciplinary team. Most commonly, it's related to the hepatologists and to the other gastroenterologists. Some of the modalities they use beta blockers. The beta blockers are there to kind of drop your heart rate, drop your pressure a bit, to try to limit the pressure in the varices, to try to stop or prevent variceal hemorrhage. They use antibiotics to prophylactically treat against the development of spontaneous bacterial peritonitis. They may also use some antibiotics and lactulose to try to increase the amount of stools you have per day in order to decrease the toxins that are floating in the blood, to limit encephalopathy. They'll use diuretics to control the pressure. They'll use the diuretics also to control ascites. There's the disease-specific therapies. You know, depending on the cause of the underlying cause of the liver disease, you may take antivirals to eliminate the hepatitis C or to keep the hepatitis B virus in check. You may take immunosuppression medications if you've got an autoimmune disease such as PBC, PSC, or autoimmune hepatitis. If you've got something like hemochromatosis or Wilson's disease, they may use chelating agents to try to drop the iron or drop the copper content within the body. For alcohol, abstinence is one of the approaches that would be disease-specific. For fatty liver disease and metabolic disease, diet modification and exercise. And then finally, if you've got something like Budd-Chiari with a hypercoagulable state, then you may be taking an anticoagulation medication to try to prevent further clotting. They also practice or ask you to do sodium restriction. Sodium restriction is there to try to decrease the fluid accumulation that would eventually lead to ascites. Albumin infusions occur. Those primarily occur after you've had a paracentesis and you're already struggling with ascites. Endoscopy is used. They use endoscopy to go down and evaluate the varices. And if the varices are large enough or threatening enough, they will do banding to try to control them and get them to scar. And then one of the final things that can be done is TIPS. So TIPS stands for transjugular transjugular intrahepatic, oh my God. Portal systemic shunt is what close enough. Anyway, they'll use the TIPS. TIPS is basically, punching a hole through that blockage in the liver and basically just plowing the roadblock out of the way so that you can directly connect the portal vein to basically the hepatic veins in the vena cava to get the blood directly through the liver. The complications related to that, which limit its use, are it's very effective at eliminating ascites if you're struggling with that. However, it does increase your rate of encephalopathy to the point where some patients can't tolerate it and can't handle it, and it needs to be shut down. And you just go back to your previous state. And then finally, and where I live my world, and why I don't need to pay attention to all this other stuff, is liver transplantation as probably the final and end therapy for people who are decompensated and need life-saving therapy to continue living after they've had their liver disease. And basically what we do with liver transplantation is we divide the vena cava just below the heart, we divide the vena cava just below the kidneys, which sit right here, we divide the artery, the portal vein, and the bile duct, and we take the liver out, and then we sew a new liver in at each of these new places from a donor, and whether that's a living donor or a deceased donor, that's how it's done. Now, if it is a living donor, the one thing we do differently is we leave the vena cava in place and we basically peel the liver off of the vena cava so that that recipient's vena cava stays in place, because from a living donor, we can't take the vena cava, and then we just sew everything back in a similar fashion, but we lay the liver piece on top of the recipient's vena cava. Some people do that even for deceased donors, but the way we do it here in Memphis is just like this: divide here, and replace the whole vena cava. So I think that's my last slide, so I will open it up for questions. I think I was more brief than I was supposed to be, but after 3 nights of not sleeping this week and throwing together slides at the last minute last night, this is what you get. So, any questions? All right.
Does anyone have any questions?
Thank you.
You did 3 livers, and how many kidneys this week?
We did a liver, what, Tuesday night? I did 3 kidneys Wednesday night, and then we did a liver Thursday night.
So you have an excuse.
So we're doing a liver later today.
Oh my gosh.